The characteristic auscultatory finding of mitral regurgitation is a holosystolic murmur of constant intensity, as shown by this phonocardiogram. Listen to a patient with mitral regurgitation. I will start with 3 normal beats and then add the murmur. The constant intensity of the mitral regurgitation murmur is a result of the persistent pressure gradient between the left ventricle and the left atrium throughout systole. This figure shows the direction of this regurgitant flow. This murmur is heard best at the apex, with the patient in the left lateral position. When the regurgitant jet is directed posteriorly, this murmur radiates towards the left axilla. If the regurgitant jet is directed anteriorly towards the sternum, the murmur radiates towards the left sternal edge. Mitral regurgitation will increase in response to hand grip maneuver. Listen to the change in this murmur with a hand grip maneuver. Rest. Hand grip. This murmur extends all the way to the second heart sound, reflecting the significant gradient that exists between the left ventricle and the left atrium throughout systole. Common etiologies of mitral regurgitation include myxomatous degeneration of the mitral valve, as shown in this figure. This figure shows an example of mitral regurgitation as seen by color Doppler echocardiogram. In summary, mitral regurgitation presents with a holosystolic murmur of constant intensity, which is heard best at the cardiac apex. Listen once again to a patient with mitral regurgitation. The murmur of mitral stenosis is a low-pitched, rumbling, diastolic murmur as shown here in the phonocardiogram. This murmur is heard at the cardiac apex with the patient in the left lateral position using the bell of the stethoscope. The presence of an opening snap should alert the clinician to look for mitral stenosis. I will start with 3 normal beats, and then add the opening snap, and then the murmur. Having the patient lie on their left side brings the heart closer to the chest wall and makes this murmur easier to hear. With exercise, the gradient across the stenotic mitral valve becomes larger. When a patient's heart rate is above 90 beats per minute, the diastolic murmur of mitral stenosis can be confused with a systolic murmur because systole and diastole are nearly equal in duration. One way to avoid this pitfall is to simultaneously palpate the carotid pulse to establish the onset of systole. Echocardiography can demonstrate the degree of stenosis as well as the size of the left atrium. With calcific mitral stenosis, the opening snap can be lost, but the murmur remains. In patients with appropriate anatomy, mitral stenosis can be treated by a balloon valvuloplasty procedure as shown here. In summary, mitral stenosis is a low-pitched, diastolic rumbling murmur which is heard at the cardiac apex with the bell of the stethoscope. The murmur of aortic regurgitation is a high-pitched diastolic murmur that begins immediately after the second heart sound, as shown in the phonocardiogram. This murmur is usually heard in the third or fourth left intercostal space with the patient leaning forward. The length of this murmur is directly related to the regurgitant volume in most patients. Typically, a pulse pressure greater than 100 millimeters of mercury accompanies severe aortic regurgitation. The murmur of aortic regurgitation is heard best with the diaphragm pressed firmly against the chest wall. This murmur can be increased by having the patient tighten both fists. Listen to the change in the murmur of aortic regurgitation with a hand grip maneuver. Rest. Hand grip. If this murmur is heard at the lower right of the sternum, then aortic root pathology such as an aortic aneurysm should be suspected. Echo Doppler studies can show the severity of aortic regurgitation. Notice how this color jet coincides with the onset of the murmur. This figure shows the direction of regurgitant flow in this disease. In summary, the murmur of aortic regurgitation is a diastolic, decrescendo murmur which is high-pitched in character and heard best in the third or fourth left intercostal space. The murmur of aortic stenosis is a harsh, diamond-shaped murmur as shown by this phonocardiogram. Listen to a patient with aortic stenosis. I will begin with 3 normal beats and then add the murmur. This murmur is heard best at the second right intercostal space with the diaphragm of the stethoscope. The severity of the stenosis is related to the delay in the peaking of this murmur. The later the murmur peaks, the more severe the stenosis. Aortic stenosis is often associated with a delayed and diminished carotid pulse. Notice the normal carotid upstroke on the left and the delayed one on the right. In many adult patients, aortic stenosis occurs in the setting of a congenital bicuspid aortic valve. Once the valve calcifies, the second heart sound may become inaudible. In some patients, the murmur of aortic stenosis may be heard at the cardiac apex with a higher pitch. This phenomenon was first described by Gallavardin. This murmur is heard best with the patient sitting up and leaning forward. Echo Doppler studies can directly measure the gradient across the aortic valve, allowing a calculation of aortic valve area. In summary, aortic stenosis presents with a harsh, diamond-shaped, late-peaking murmur heard best at the second right intercostal space with the patient leaning forward. Listen once again to a patient with aortic stenosis. The third heart sound occurs in early diastole, shortly after the second heart sound, as shown by this phonocardiogram. Listen to a patient with the third heart sound. I will begin with 3 normal beats and then add the third heart sound. The third heart sound is heard best at the cardiac apex with the patient in the left lateral position. In those over the age of 40, a third heart sound usually indicates decreased left ventricular function. A third heart sound is usually heard with the bell of the stethoscope at the apex. This sound occurs as a normal variant in children. A third heart sound may also occur as a normal finding in young adults. Patients over 40 who have a third heart sound usually have a decreased ejection fraction. A third heart sound can be difficult to detect because it occurs in the shadow of a louder second heart sound. A third heart sound can occur in volume overload states such as mitral regurgitation. A third heart sound may be palpable at the cardiac apex. In summary, third heart sound is a low-pitched, early diastolic sound heard best at the cardiac apex using the bell of the stethoscope with the patient in the left lateral position. The fourth heart sound occurs in late diastole, shortly before the first heart sound, as shown by the phonocardiogram. Listen to a patient with a fourth heart sound. I will begin with 3 normal beats and then add the fourth heart sound. The fourth heart sound is heard at the cardiac apex with the patient in the left lateral position. A fourth heart sound indicates that a ventricle is stiff and non-compliant. A fourth heart sound may be palpable at the apex. A fourth heart sound feels like a double impulse at the cardiac apex. When a fourth heart sound is added to a normal first and second heart sound, a triple rhythm is created. Although a fourth heart sound is due to a forceful atrial contraction, it actually originates in the ventricular wall. The most common cause of a fourth heart sound is hypertension. Poorly controlled hypertension leads to left ventricular hypertrophy in many patients. In summary, a fourth heart sound is a low-pitched, late, diastolic sound heard best at the cardiac apex. Summation gallop. As the heart rate increases, a third heart sound from one cardiac cycle may coincide with a fourth heart sound from the following cycle. In this case, a single loud diastolic sound is heard as the two sounds superimpose on each other. Listen to a patient with a summation gallop. I will start with 3 normal beats and then add the summation gallop. Summation gallops are usually heard best at the cardiac apex with the patient in the left lateral position. The most common medical conditions where summation gallops occur are end-stage dilated cardiomyopathy, end-stage ischemic cardiomyopathy, or left ventricular aneurysm. On occasion, A patient may have both a third heart sound and a fourth heart sound. At heart rates below 90 beats per minute, there can be a quadruple rhythm. Listen to a patient with both a third and fourth heart sound. I will start with 3 normal beats, and then add the third heart sound, and finally the fourth heart sound. At cardiac catheterization, the third heart sound occurs during early peak ventricular filling, and the fourth heart sound coincides with atrial contraction. A summation gallop is located midway between 2 cardiac cycles. At these heart rates, it is easy to confuse systole with diastole. Many clinicians use the onset of the carotid pulse to time systole in this setting. Some patients with a summation gallop may have only a third heart sound or only a fourth heart sound when the heart rate falls below 90 beats per minute. Listen as the heart rate of a patient with a summation gallop decreases to reveal an underlying third heart sound. In general, summation gallops are usually louder than either a third or fourth heart sound alone. Listen once again to a patient with a summation gallop. In summary, above a heart rate of 90 beats per minute, a third heart sound can be superimposed on a fourth heart sound to create a loud summation gallop. Slowing the heart rate can allow one to distinguish whether the gallop is a third sound, a fourth heart sound, or both. Listen once again to a patient with a summation gallop. Innocent systolic murmurs are due to turbulence across the normal aortic or pulmonic valve. These murmurs peak early in systole, as shown by this phonocardiogram. Listen to a patient with an innocent systolic murmur. I will begin with 3 normal beats and then add the murmur. These murmurs are usually heard best in the second right intercostal space when they are due to turbulence across the aortic valve. Innocent systolic murmurs can also occur due to turbulence across the normal pulmonic valve. In this case, the murmur is heard best at the second left intercostal space. This transesophageal echocardiogram shows the area at the tips of the aortic leaflets where innocent systolic murmurs are thought to originate. M-mode echocardiography has demonstrated high-frequency vibrations of the aortic valve which correlate with the pitch of innocent systolic murmurs. With practice, most physicians can reliably recognize an innocent murmur by the early peaking of this murmur and the lack of any pathologic findings. In older adults, systolic ejection murmurs are often attributed to aortic sclerosis with thickening of the aortic valve, as shown on the left. The thickened aortic valve in this setting identifies patients at increased risk of future cardiovascular events. Innocent murmurs, on the other hand, have no associated cardiovascular abnormalities, as shown by the normal aortic valve on the right. With practice, most clinicians can reliably recognize an innocent murmur by its early peaking and distinguish it from a late peaking murmur of aortic stenosis. Listen to the difference between these two murmurs. I will start with an innocent murmur, as shown by the phonocardiogram on the top, and then play an aortic stenosis murmur, as shown by the phonocardiogram on the bottom. And now aortic stenosis. In summary, innocent systolic murmurs are due to turbulence across the normal aortic or pulmonic valve. These murmurs occur in more than 50% of normal individuals and are the most common murmur heard in a general medical population. Listen once again to a patient with an innocent systolic murmur. Review session. I will now play each of the sounds you have just learned and pause to give you time to identify the sound. I will then give the name of the sound. Recorded at the 4th left intercostal space. Aortic regurgitation. Recorded at the 2nd right intercostal space. Aortic stenosis. Recorded at the apex. Fourth heart sound. Recorded at the apex. Mitral stenosis. Recorded at the apex. Mitral regurgitation. Recorded at the apex. Third heart sound. Recorded at the second right intercostal space. Innocent systolic murmur. Recorded at the apex. Summation gallop. If you did not recognize each of these sounds, you may want to listen to that audio chapter again. Thank you for taking the time to listen to this program. I hope you have found this information to be both enjoyable and useful in your care of patients.